Good evening. My name is Jin-Lin Hou from Nanshan Hospital South Medical University, based in Guangzhou, a city next to Hong Kong. I would like to talk something about a novel aMAP score system, which could be used to predict HCC development in hepatitis patients with different etiology and ethnicities. This data generated from global network. As all you know, HCC is the sixth most common cancer and the second leading cause of cancer mortality worldwide. HCC is a high prevalence area in China and South Asian countries. HBV and HCV infections are the leading causes of HCC development. In China, over 80% of HCC patients could be found HBV infection. Over the past few decades, a number of HCC risk scores have been developed and validated to stratify the risk of HCC development for kinds of chronic hepatitis. Most of the risk scores are from hepatitis B patients, either treated or untreated patients. This table summarizes the existing HCC risk score for chronic hepatitis B patients. However, there are a lot of limitations because most of these risk scores assign heavy weighting to biological factors and perform only satisfactorily among populations with specific etiology, either from hepatitis B or hepatitis C, and different ethnicities, thus limiting their widespread applications worldwide in current era of sustained virological response to Hep B or clearance by using antiviral therapy for Hep B. Thus, our aim is to develop and validate a novel, accurately, globally applicable risk score system for predicting HCC occurrence through international cohort collaboration. Our patients from 11 prospective observational cohorts or randomized controlled trials conducted in 29 countries on 5 continents for this study. These 11 cohorts included 4 Asian cohorts with HBV, 2 Caucasian CHB cohorts, 3 HCV cohorts, and 1 non-viral hepatitis cohort. All patients in Hep B and Hep C cohorts were receiving antiviral therapy. All have been cured after antiviral therapy, among which such B cohort is an antiviral-treated CHB cohort conducted in 15 sites in China, in which about over 70% patients were treated with entecavir or tenofovir. RIM cohort with our 2,500 more patients is a BMS-sponsored randomized controlled trials from 50 sites across China. We also included patients from European page PB cohort with over 1,900 patients across 10 sites from Europe. We also included cohort from Jin-Lin cohort from 4 randomized controlled trials, either treated with tenofovir or TAF. 3 different cohort, HCV cohorts, Japan HCV cohort, UK cirrhotic HCV cohort after sustained virological response cohort, gated cirrhotic HCV cohort after clear HCV. Small non-viral hepatitis cohort are from Japan. Most of them are from lab. In this cohort, cirrhosis and HCC diagnosis were based on standard histological and all compatible radiological findings. Diagnosis criteria of cirrhosis and HCC were different across different cohorts. Patient advanced the evolution at least 6 months. This table shows the clinical characteristics of patient cohorts. Other than the 2 HCV sustained virological response cirrhotic cohort, the percentage of cirrhosis patients in other cohorts ranged from 11.4% to 27.4%. During a median of 3 to 9 years of follow-up, 631 patients developed HCC. Besides, we also calculated the albumin-bilirubin ratio, abbreviated to ALBI for each patient. ALBI score is a very simple index reflecting the underlying liver function evaluated by albumin and the total bilirubin levels, which was extensively used in clinical practice. In this study, patients from site with the largest sample size from Nanpang Hospital as a training cohort or as a cohort as a validation cohort. This table shows variables. By conducting univariate analysis, we find that cirrhosis, E antigen state, QHBsAg, liver stiffness measurement. It is a non-invasive test to detect liver fibrosis. Age, sex, ALBI, and platelet were associated with the occurrence of HCC. Considering that the cirrhosis diagnosis in clinical practice is relatively subjective, and the LSM levels is not easily available in a lot of sites, E state and QHBsAg were viral related parameters. We confined our risk score to the last 4 non-variable age, sex, ALBI, and platelet. At risk score called the age, male, ALBI, platelet. Short words means aMAP score was devised using the above four variables weighted by regression coefficients in the multivariate analysis. Then the score range was standardized to 1 to 100. The text box at the bottom showed the formula of aMAP risk score. The C-index of aMAP score was 0.82 compared with other risk score. It did not improve subsequently when cirrhosis or liver stiffness measurement value were included in the model. C-index was both over 0.80% among patients without achieving a negative HBV DNA state, especially where the C-index was 0.74 and 0.75 in patients with without cirrhosis, respectively. 50 and 60 as the two optimal cutoff values were used to separate training cohort into low risk, medium risk, and high risk groups. We can see from the left table that around 60% patients were assigned to low risk group within 5-year cumulative incidence of HCC of 0.8%, where the corresponding rate in high-risk group was about 20%, which is 25 times of that in lower risk groups. The performance of aMAP score were externally validated in other cohorts. In this table, we can see the aMAP score not only performed very well in other Asian and Caucasian HBV cohort, but also in HCV cohort and a small non-viral hepatitis cohort, which C-index between 0.82 to 0.87%. Within the subgroup of cirrhotic patients, the C-index value for predicting HCC ranged from 0.61 to 0.83%. Our study also has a few limitations. Firstly, the patients were recruited from tertiary hospital mainly, as well as some infectious disease hospitals, were especially like to have active disease before antiviral therapy. Secondly, the PP value of aMAP score at a cutoff value of 60 was not optimal. Third, the discriminatory ability of aMAP score was suboptimal in case of cirrhosis patients. Fourth, our formula for aMAP score is relatively complex. Mr. Chairman, ladies and gentlemen, here is our conclusion. The aMAP score is the first score to facilitate accurate, reliable, and simple to use prediction of occurrence of HCC irrespective of etiology and ethnicity. This objective score is based on 5 routine clinical laboratory parameters without inclusion of etiological factors. Patients with aMAP score less than 50 defined as a low-risk group, accounting for 45% of our population, had a HCC incidence of less than 0.2% per year. This score will be useful tool for improving early HCC detection, thus leading to the high survival. During last decade, many predicting models has been established. However, less has been validated and quite a few has been applied. Currently, we plan to using our aMAP score to screen nearly 1 million patients with chronic hepatitis from 1,000 more hospitals across China. Finally, I would like to acknowledge my colleagues as well as other collaborators, Professor Giorgio Pampastoris and other collaborators. Thank you for your attention.